suture lysis is often performed for postoperative intraocular pressure control in a trabeculectomy surgery which needs special lenses and laser to perform it. Application of releasable sutures minimizes the need for postoperative laser suture lysis. This video illustrates the steps of trabeculectomy surgery with an emphasis on placement of releasable sutures. After raising a fornix-based conjunctival flap and bleeders cauterized by gentle cautery, care taken not to char the tissues, a 0.2 mg per ml mitomycin C soaked microsurgical sponges are placed under the conjunctival flap and left it under for a duration of 2 minutes. Mitomycin C sponges are removed and the ocular tissues are irrigated thoroughly with balanced salt solution that reduces the intraocular diffusion of mitomycin C. A triangular incision is made adjacent to the corneolimbal junction and is deepened. Partial thickness scleral flap is raised and advanced carefully, avoiding buttonholing or tearing of the flap until at least 1 mm of bluish grey zone of peripheral cornea is exposed. The section is widened with a crescent. A self-sealing beveled limbal stab incision is made before entering the anterior chamber under the scleral flap. Viscoelastic is injected. Anterior chamber is then entered with a keratome just behind the hinge of the scleral flap. The flap of the deep limbal tissue is excised using a scleral punch. Chamber is filled with viscoelastic and peripheral iridectomy is done using a scissors. To avoid postoperative hypotony, sutures are placed around the margins of the flap that can be fixed sutures or releasable sutures. This video highlights the placements of sclerocorneal releasable sutures. First, a sclerocorneal reverse bite is taken. The second bite is a corneoscleral bite taken 2 mm away from the initial bite. It should be a partial thickness superficial bite to avoid buttonholing at the base of the flap. The third bite is from sclera to sclera involving flap margin and the intact sclera. A loop is formed near the flap end. 4th hose and the loop are used to tighten the suture. The end of this suture is cut 0.5 to 1 cm long and should be kept under the conjunctiva. Similarly, releasable sutures is placed on the other end of the flap margin. The ends of the first bite of the releasable sutures are cut 0.5 cm long. Anterior chamber is reformed. Conjunctival closure is as important as a good flap closure to minimize postoperative leak and hypotony. 80 vicryl sutures are used. Episcleral tissue is also taken in the bite. The two limbal conjunctival sutures should be taken tight enough to hold a 1 mm conjunctiva onto the limbus. This will prevent conjunctival retraction and bleb exposure postoperatively. Anterior chamber is formed through paracentesis site. Suture release postoperatively can be done from day 1 to 1.5 months, after which fibrosis results and suture breaks while attempting its removal. Suture release can be done by holding the corneal loop with suture removal forceps and gently pulling it down. Bleb is raised by gentle massage. Releasable sutures, a method to remove the scleral flap sutures at the slit lamp, circumvents the need for a laser. In laser suture lysis, blood, Tenon's fascia, conjunctival pigmentation or fibrovascular tissue can obstruct the view of the suture to release the flap. Additionally, the conjunctiva can be buttonholed by the laser, or stresses to the bleb can create wound leaks, both of which may produce hypotony and increased risk of bleb-related endophthalmitis. The advantages of releasable sutures are its relative ease of suture removal, lack of bleb manipulation, avoiding stresses on the bleb and buttonholing. It reduces the need for argon or diode laser and the need for use of special blue menthol or Hoskin lens, and reduces the need for patient's cooperation.